Thank you, Dr. Kamal Sharma and team, for having me here to speak on the topic of localization of pathways. I would stick to the basics of narrow complex tachycardia and localization of the tachycardia based on tachycardia ECG. The first step is to differentiate between AVNRT and AVRT based on the P-wave morphology, QRS alternance, STT changes. Then you can localize the pathway site based on the P-wave morphology and the STT changes. And based on sinus rhythm ECG, the pre-excitation, when you can localize the pathway. So step one would be first to differentiate in a AVNRT and AVRT in a narrow complex tachycardia. Step two would be locate P waves and localize based on it. Step three would be location based on STT changes. And once the sinus rhythm is achieved and there is pre-excitation, step four would be localization based on pre-excitation. So how to differentiate between AVNRT and AVRT? AVNRT, the ECG shows R prime in V1 and pseudo S in inferior leads. That is because of the retrograde P waves in the terminal part of the QRS. The rate is generally of 150 to 200. The P waves, if seen, are negative in inferior leads, and 1-to-1 AB relationship is not mandatory. While in AVRT, STT changes are present because possibly of P waves falling on the T waves. QRS alternance may be seen, the rate is faster, and if seen separately, P wave morphology can help in localization. 1:1 relationship is mandatory. AVNRT is basically from the AV junctional area where there is a slow pathway and a fast pathway, and a typical AVNRT is a slow fast AVNRT. Here the P wave overlaps with the QRS complex and as activated at the same time. So therefore you may not see P waves at all the time, or if it is present, it is in the just at the terminal portion of the QRS as R prime in V1 and pseudo S in inferior leads. So seeing this tachycardia ECG, you see this R prime and you see the S waves in 2,3 AVF. When the tachycardia terminates after carotid sinus massage, you don't see this R prime and the pseudo S waves. So therefore, this becomes a typical AVNRT. So comparison between the two same, R prime which is present and the pseudo S which is present in this patient is not there. This is typical of a typical AVNRT. What about AVRTs or related to WPW? They are generally short RP tachycardia most of the times. P waves are separate from the QRS on either the ST segment, which causes the STT changes, or they can be on the T waves causing a T wave notch, or a separate P wave may be seen differently. So there is a pathway separately other than the AV node. It's an orthodromic AVRT resulting in a narrow QRS. So antegrade goes via the AV node, retrograde goes via the pathway, and this completes the circuit. So let us see this tachycardia ECG here. Narrow complex fast tachycardia. You can see QRS alternance, there's no R prime, but there is a notch on the T wave if you can see, but the P wave is not very well appreciated. QRS alternance is here also, and therefore likely to be AVRT. The tachycardia when terminates shows a baseline short PR interval with pre-excitation, R wave being positive in V1, therefore suggests WPW. So what about the tachycardias with accessory pathways? It can be orthodromic tachycardia, which we commonly see, or it can be antidromic or a bystander. So we'll discuss more about orthodromic tachycardia. It is generally re-entry associated with WPW. There are other forms with their antidromic tachycardia like MAHEM and a PGRT, which is a slow kind of retrograde conducting pathway. So important is the ventricle forms a part of the circuit. The ventricle is a part of a circuit. So the step two is when you can see the P wave morphology. Now here in this tachycardia, it's a narrow complex tachycardia, and you can see that this P wave is inverted into 3 AVF, which is causing the ST segment to be there, and there is a bump in the T wave which is possibly positive. So if you have this kind, it is suggesting that the P wave is retrograde coming from the inferior area, and therefore is likely to be an inferior pathway. Based on the STT changes, if you have significant STT changes in the inferolateral leads, that means the P wave is somewhere there, and therefore the pathway is likely to be in the infralateral area, maybe the left lateral or left posterolateral. In a long RP tachycardia where the P wave is separately seen, here you can see a slow tachycardia ongoing, but the P wave morphology is 2,3 AVF is negative and V1 is actually positive, suggesting that it is arising from near the AV nodal region and likely to be a PGRT, a long AV tachycardia. To confirm this, a carotid sinus massage terminating the tachycardia suggests that it's a AV nodal dependent tachycardia. Now coming to the last step, that is localization based on the sinus rhythm, pre-excitation as a must. Either it's a left-sided or a right-sided arrhythmia, and the differentiation between the areas is as mentioned in this figure, but we'll go with the localization. Most commonly is in the left lateral region and then goes to the posterior, then right side and the anterior region. So the WPW ECG characteristics as shown in the ECG are short PR interval in sinus rhythm, QRS being wide more than 120 milliseconds, a delta wave which is a slur in the start of the QRS, and STT changes are present because of secondary QRS widening. The localization based on ECG, the presence of pre-excitation is a must. Algorithms from 1945 by Rosenbaum et al. To right now, there are many algorithms. The limitations are inter-observer variation and non-producible results by independent different studies. You need to have a good amount of pre-excitation and the QRS should be more than 120 milliseconds. Initial delta wave of 20 to 40 milliseconds is a must. There may be difficulty if there is an isoelectric start or defining the morphology is difficult. If there are multiple pathways in structural heart disease, it becomes difficult to localize. So let us see the basic types of localization. So Rosenbaum in 1945 had the seminal paper showing the types of pre-excitation. So in short, if you have a positive R wave in V1, that is RBBB, it's a left-sided pre-excitation. And if you have a LBBB in V1, then it is a right-sided pre-excitation. Inferior leads negative, that means it's a posterior pathway, and inferior leads positive means it is an anterior pathway. Then came the Milstein algorithm, then is the Aruda algorithm, and many other algorithms being there. But I would like to discuss this algorithm for localization, which was given by Pamberg and Hassegray et al. And the step 1 remains the same. If V1 is positive, it's mitral annulus, V1 negative, tricuspid annulus. If you have V1 which is positive and you think it's a left-sided, then step 2 would be how many inferior leads are positive. More number positive, that is all 3 positive, 2, 3 AVF, then it becomes a superior placed or left lateral pathway. If there are 1 or 2 which are negative, then it becomes a posterolateral area, and if all are negative, it becomes a posteroseptal or a posterior pathway. To differentiate between posterior, lateral and a posteroseptal pathway, the ratio of V1 to 1 is important. If V1 is taller than lead 1, that is the ratio is more than 1, it is a posterolateral pathway. If the V1 by lead 1 R wave ratio is less than 1, it becomes a posteroseptal pathway. And if there is a notch in the descending limb of lead 2, then it may be a deep cardiac pathway. So carotid and coronary sinus pathway. Going to the right side, the tricuspid annulus, if V1 is negative, then you go to this again the inferior leads, 3 positive showing that it's a right anterior or a right anteroseptal, 1 or 2 positive right lateral or right septal, and all 3 negative means right posterior or posteroseptal. How do you differentiate between these septal versus the lateral is where the transition is. If the transition is in V2, then it is likely to be septal. If the transition is V3 and more, then it is likely to be a lateral pathway. So this helps us localize the pathway when there is pre-excitation. So let us share some examples. Step 1, V1 positive, left side, then step 2, 2, 3 wave positive. That means it's a left lateral pathway. If 1 in AVL is negative, that means it's a left high lateral pathway. Again, pre-excitation, V1 positive, V2, so all 3 are positive here, again left lateral, but here 1 and AVL are towards more positive, and therefore it becomes a total left lateral rather than a high lateral pathway. Again V1 positive, and here you can see that 2, 3 AVF are equiphasic, they're not totally positive, while 1 is positive. You can see that this is a left posterolateral pathway. Here the lead V1 is more positive as compared to lead 1, and therefore a left posterolateral pathway. Again V1 positive, but 2, 3 AVF being negative, so it becomes the posterior region, and here the ratio of lead 1, so 1 is more positive as compared to V1, and therefore becomes a left posteroseptal pathway. The next is a V1 positive, and what you see again is a 2, 3 AVF negative, so left posterior. 1 is taller than lead V1, and therefore it is a left posteroseptal, but there is a notch in the descending limb of lead 2, suggesting that this is a left-sided pathway. However, it can be in the deep coronary sinus. When V1 is negative, then you see for 2, 3 AVF, and all three are negative here, suggests that this is a left posterior pathway. The transition being in lead V2, therefore it becomes a left posteroseptal pathway. Again here the pre-excitation, V1 is negative, the step 2 would be 2, 3 AVF, so here only 2 is positive, but 3 and AVF is negative, therefore it's likely to be left posterior, and the transition is basically in more than V3, V4, so left postero or left lateral pathway. Here the step 1, V1 is negative, then we go to 2, 3 AVF, which is positive, and once you see that this is positive, it becomes a right anterior pathway, and the transition is in V3, so it becomes a right anterolateral anteroseptal pathway. So based on these, tachycardia ECG helps to differentiate AVNRT from AVRT. P waves and STT changes, if seen, can localize the pathway. Pre-excitation on sinus rhythm localizes the pathway, and localization of pathway helps while doing an EP study and RF ablation. Thank you for your patient listening.